Thank you, Devang, and thank you, Professor Ramanjit, for including me into this program.
I think, Dr. Pandav, you have to come a little closer to your.
Talking about achieving the
yeah.
target IOP, in using medical and surgical management. So we have already heard, the importance of target IOP and where it should be roughly in case of children. But how do we get this? There is we have a number of options. We have medical treatment and we also have surgical option. But pediatric glaucoma, congenital glaucoma mostly is surgical condition. So the medical options are only when you are waiting for the surgery, or somehow it's going to facilitate your surgery, like it clears up the cornea temporarily so that you can go in and do a definitive procedure. Or you could do, you could use it, post surgery, because if the IOP is still not controlled and you planning to do something else, or adding 1 or 2 drugs if the pressure comes down to your target IOP somewhere around 15 millimeters of mercury. If the surgery has already failed, you have no option but again to go back to medicines. And if sometimes the surgery is too risky, or the eye is already blind and you don't really want to do any surgery, so there are a number of situations still that you would like to do medicines. But having said that, management is mostly surgical for congenital glaucoma. So what drugs you can use? It most of the drugs can be used theoretically, but they have their side effects, and more so in children. So children they tolerate the carbonic anhydrase inhibitors quite well. But you have to be mindful that sometimes you could have a metabolic acidosis because the body weight is small. So even 1 drop actually, by body weight, is a large dose for the children, especially in the neonates. And there may be some concerns of growth retardation. Pilocarpine and prostaglandin similarly can be used. Pilo is not generally used much, but it can be used if nothing else is working. Beta blockers are effective in reducing intraocular pressure in children, but then you have to be careful that they do induce bradycardia, and sometimes they can lead to apnea as well. Brimamine is best avoided in children because it crosses the blood-brain barrier and can lead to severe CNS depression in children and could be dangerous. So with that, we'll come down to the surgical management. We had a number of options: trabeculotomy, goniotomy, GAT, trabeculectomy, with trabeculotomy, or trabeculotomyces, and even tubes are an option. So when the cornea is not clear, you have to have an external approach, where it could be a trabeculectomy or combined trap could be done. So this video is a small child, 23 years old, which I operated actually in 2002. So there's a very old video. Essentially, what you do is you create a, like trabeculectomy, you create a limbal or fornix-based flap. In this case, I use a limbal-based flap, and you dissect out the triangular scleral flap. And once that is done, you have to identify the scleral bed, identify the area where the Schlemm's canal is likely to be there. So there's a junction of the gray and the white zone. And once you are there, you carefully, made a radial cut. So identify the Schlemm's canal there. And when you reach the Schlemm's canal, you will, some fluid will start oozing through that. And that would be, like you can see some fluid is coming now. Can you see in the video? So you have some fluid started coming. So we have actually opened up the Schlemm's canal. So you can open it a little more, and you can make some, you can see the fluid is now nicely coming. It should gradually come, it should not come as a spurt. If it comes as a spurt, then you have entered the anterior chamber. So you can, you can slice it radially just to make space for to enter your probes. And then we use the Harms probe, and once it's done, so you can put these probes into the Schlemm's canal, and gently you bring it in the anterior chamber, and basically you are disrupting the tissue or the inner wall of the Schlemm's canal, and one side, and then you do it on the other side as well. So idea is to get at least 110 degrees of trabecular meshwork, which is disrupted, and the Schlemm's canal is exposed to the anterior chamber. And once that is achieved, we can just close the scleral flap and also the conjunctival flap, and that should take care of it. So again, you have the angle dysgenesis, or if there's an angle, no, if there's a lot of angle dysgenesis, not much of a dysgenesis, then one can use, or the cornea is clear, then you can actually try a trabeculotomy, which is this video. I'll show you a small video of trabeculotomy again. So what you do is you have a go through a MVR knife and identify the angle structures, and again try to cut this tissue. When you cut this tissue, the iris will fall back a little bit, and by try to do it as much as you can, at least 110, or two quadrants. Through single port, you can make multiple ports to achieve a larger extent of trabeculotomy. So, okay, and the third procedure which we can do is the gonio-assisted transluminal trabeculotomy for these. So this is a 360 degrees trabeculotomy basically. So what you do here is that, you take a little, proline suture and make the end a bit bulbous. Under anesthesia, then you have to make, with MBR, make a port at convenient position, usually where you are sitting, constrict the pupil with the pilocarpine, and then you have to make another and inject some viscoelastic to maintain the anterior chamber. Then you make another port through which you will insert the proline suture. And once proline suture is inserted, you with a direct gonioscope, now we can create a little opening in the trabecular meshwork. So Schlemm's canal is exposed, and when that is done, this proline suture is then you grab the suture with the forceps, and then it is threaded into the Schlemm's canal. So it goes, round and round, and it'll go 360 degrees. So you wait for it to come back to from where you started to the same incision. It will show up there. And once that happens, we grab it with the forceps, remove the gonioscope, and just pull the thread out. So this is going to rip the trabecular meshwork 360 degrees. So it's like doing a 360 degree goniotomy. So these very gratifying result with these procedures, because here except for the external trabeculotomy, when you're doing it goniotomy or GAT procedure, you're not handling the conjunctiva, so that leaves scope for the subsequent surgeries as well. So up to 80% results, success rate has been reported at under 2 years of age, but after that age, the goniotomy and trabeculotomy doesn't perform that well. Advantage with 360 degree trabeculotomy or GAT-like procedure is that you could end up with the 80 to 90% success rate, and there's no need to repeat because we have already removed 360 degrees. And if it fails, then you have a conjunctiva which is intact for subsequent surgeries as well. So trabectomy is kind of a newer procedure. It has not been much tried in children, but Cahook's blade, cutting off trabeculectomy or trabecular meshwork with Cahook's blade has been reported and perhaps could be used in children as well. Again, if these procedures not fail or we are not doing it, then we have our gold standard, or in what its procedure to fall back on is a trabeculectomy. And trabeculectomy with mitomycin or without mitomycin can be done. But if we are doing it with mitomycin C, the results, the success rate is higher, and you can get lower IOP. So that will meet your requirement of the target intraocular pressure. And also, you can see this patient, you have a half striae, but the cornea is now clear, has undergone a trabeculectomy, has a nice diffuse bleb, and the IOP is well controlled. 60 to 80%, 67 to 87%, and 1 year results have been reported with this procedure with trabeculectomy with mitomycin C. But as you know, that the failure rate kind of increases with the increased follow-up, so that we have to keep in mind. And all these patients, whatever procedure has been done, they have to be followed up very meticulously. If all these procedures fail, then we have tubes for these kids, and though they are not the first line of therapy, they are kind of and towards when we've exhausted other means. So AGV as well ADI can be tried in these procedures. We have ADI. ADI is like a wearable implant. So AGV is a valve device, where ADI is a non-valve device, which is cheaper than ADI and is easily available in India. So if you look at the prospective randomized studies with Ahmed implant and TRAV with mitomycin C, they quite kind of, now this is for cases which are quite interactable. So here, the Ahmed appears to be, the tube surgery appears to be doing better than the TRAV with mitomycin C in terms of success rate as well as in terms of complications. And this is our own data on RD in, in children with refractive glaucoma, not necessarily, primary congenital glaucoma, but the pediatric age group, and where we have used aqueous, Arvind aqueous drainage implant. And you can see the IOP is significantly drops from preoperative to almost, there's sustained decrease in IOP for up to 2 years follow-up that we had. And if you look at the survival function, again, even the primary congenital glaucoma as well as secondary congenital glaucoma, in both cases, there's a significant drop and in IOP. The IOP remains controlled well in both the, both these conditions right up to 2 years. So I think in cases where nothing else is working, the tubes, they are a good option. And if tubes are not there, then probably we have to go to the cyclodestructive procedure, but that's kind of in the last. To summarize my talk, managing pediatric glaucoma is a challenge. IUP control requires persistent efforts, and we have a multimodal therapy because no one, mode of therapy can give you 100% results. So you have to be well equipped in dealing with the different situation and we work with different procedures which might be required in children from time to time to control intraocular pressure. And not only that, management also requires other, problems which come up with time, like refractory errors, amblyopia, and they might be corneal, transparency issues. So all those things need to be kept in mind while dealing with children. Thank you very much for your attention, and thanks again for the invitation to participate in this.